You ready to start? Go ahead.
Okay. Can you hear me, Prof?
Yes, go for it.
Oh, great. My name is Samo. I'll be presenting with Christopher and also Sandide. And our topic is prevention of mother-to-child transmissions. So this is a brief outline of our presentation. Firstly, I'll highlight a few noteworthy statistics, especially in relation to HIV in South Africa and prevention of mother-to-child transmissions. I will touch on the pillars of prevention, and then my colleagues will take over to tackle a bit more of these subtopics, and then I will come in during infancy and prevention of mother-to-child transmissions. Okay. So a couple of stats in the South African context. So according to the 2020 statistics, which we obtained from the Joint United Nations Program on HIV and AIDS, the UNAID, there's about 7.8 million people living with HIV, of which 4.8 million are women and 2.7 million of them are men. So 310,000 of them are children. So vertical transmissions, essentially mother-to-child transmission, accounted for about 11,600 infections in 2019 alone, of which majority of them occurred during the breastfeeding period, which the percentage is 69%. And with appropriate interventions, of course, new infections in the same year declined by 51% in comparison to the period of 2009-2010. And new infections at birth declined from 18,300 in 2010 to 3,600 in 2019, which is essentially an 80% decline. This was largely attributed to mothers being on ART during the antenatal period and during labor and delivery. Lastly, new infections related to breastfeeding declined from 22,000 in 2010 to about 8,000 in 2019, which was a significant 63% decline. So this, I mean, the moral of the story is that we have a good story to tell, but then we're still having a problem of vertical transmissions. And with the good guidelines that we have and enabling policies, we should be not be having as many transmissions as we do.
So your voice is very problematic, Dr. Mhlongo. Let's just see if you can help with that, but just to warn you. And just to mention, I think that even though it's, we've improved, the story is good, but breastfeeding change is not as good as vertical transmission in pregnancies, so in labor. Important point to make.
Definitely, Prof. Using headphones, I'm not sure if you can hear me now.
Yeah, I think
a little bit better.
It's slightly better. Go ahead, never mind. Proceed.
All right. Can I please have the next
slide? It's much better now.
All right. Can I please have the next slide? All right. So this slide basically shows the risks of vertical transmission from HIV positive mom to baby during the different stages of pregnancy, of which in our case, what we targeted was this period highlighted in red, and it yielded good results in preventing mother-to-child transmissions as compared to the years prior to 2019 in this case. Can I please have the next slide? So the PMTCT program outlines about 4 pillars by which we aim to achieve the target of zero transmission from mother to the infants, and eventually an HIV-free generation at some point. So the first pillar addresses primary prevention of HIV, especially among women of childbearing potential. So this basically involves offering HIV testing for all sexual partners. If the woman is HIV positive, then we encourage them to refer their partners to come and test. Also, importantly, it involves male partner referrals for voluntary male medical circumcision, which has been shown in studies to reduce the transmission of HIV. Also, promoting condom usage and offering pre-exposure prophylaxis. And pillar 2 addresses preventing unintended pregnancies among women living with HIV. So all HIV positive women should have access to family planning services and should be given a choice of methods they would like to use. Family planning services should be definitely an integral part of ART services, and this will help a lot. So lastly, women should be encouraged to plan their families, aiming to conceive when they're well and their viral load is suppressed, which is a common theme that is very important that we're going to touch on later on. And the third pillar involves or addresses preventing HIV transmissions from a woman living with HIV to an infant, of which I will touch on this a bit later on. But basically it involves identifying women living with HIV and getting them on ART, testing during HIV visits if they're HIV negative, and if they're positive, to get them on treatment until delivery, labor, and during the breastfeeding period. Also, importantly, to counsel women and ensuring that they adhere to treatment and understanding the risks of mother-to-child transmissions during the breastfeeding period, of which Prof, you've already highlighted that we still have a bit of problem with HIV positive women staying on treatment during the breastfeeding period, of which is a theme also that comes up in studies. Then pillar 4, basically providing a proper treatment, care, and support to women living with HIV, their children, their partners, and also their families. All right. I'm going to hand over to Chris to address the changes to prevention of mother-to-child transmission guidelines in 29 as compared to the 2015 guidelines. Sorry.
Hi, everyone. I'm just going to briefly touch on what changed in the new guidelines, which came out in 2019 compared to the previous ones. So according to the guidelines, they aim to be more practical compared to the 2015 guidelines, as well as integrate our entire healthcare, all the services in our healthcare system to include community health workers, which we'll get into more detail within the specific sections, and to increase patient education and to empower patients and especially mothers in playing a crucial role in the prevention of mother-to-child transmission. Can I please have the next slide? So the antenatal prevention of mother-to-child transmission has changed to HIV negative mothers being offered an HIV test at all 8 antenatal visits, compared to previously when it was every 3 months of pregnancy. So this is intended to increase the pickup rate of HIV during pregnancy. Also notably, the drug Dolutegravir has been introduced, and it is available for pregnant women. We'll come back to that later. the integration of community health workers, they've been integrated to educate mothers in the community who are living with HIV, mothers who are pregnant and haven't booked. The community health workers are there to educate and to try and improve the mother's knowledge of what she should be doing during pregnancy to try and improve the management of HIV during pregnancy. TB gene expert is now routinely done for all HIV positive, newly diagnosed HIV positive mothers, regardless of whether or not there are symptoms. And the TB skin test has been done away with. Isoniazid prophylaxis has also been given for 12 months for all mothers with CD4 count below 100. And compared to the previous guidelines, the new guidelines also include screening for other infectious diseases, syphilis, hepatitis B, and malaria. So in the intrapartum prevention mother-to-child transmission, we do a viral load at delivery. The stat medication, antiretrovirals for mother during delivery has been changed from AZT has been removed, and we now include Dolutegravir, intracitibine, and tenofovir with the nifedipine at delivery. And we now no longer define a high-risk mother as somebody who hasn't been on antiretrovirals for less than 4 weeks, but it's entirely objectively based on the mother's viral load, and whether we have one within 12 weeks of delivery, or if not, that'll be defined as a high-risk case. So postnatal changes. Mothers are offered 6 monthly viral loads while breastfeeding until the cessation of breastfeeding. The routine 18-week PCR for high-risk exposed infants has been done away with. And all HIV-exposed infants are offered a 6-month HIV PCR. And all babies, there's a universal testing that has been introduced for all babies at 18 months, regardless of HIV exposure. And the confirmatory test for children up to the age of 2, if they have a positive rapid, is an HIV PCR as opposed to a second rapid as it was previously. And nifedipine is continued during breastfeeding until the mother's viral load is below 1,000 copies per mole. And the breastfeeding recommendation has been increased up to 24 months as opposed to 12 months in the previous guidelines. So I just wanted to include a little bit about Dolutegravir. It's an antiretroviral in the class integrase inhibitor. It's been shown to have superior efficacy as compared to other previous, in the previous regimens. The Dolutegravir regimen has been shown to have superior efficacy. The side effects are mild and uncommon, and there's a high genetic barrier to resistance. Just of note, there are drug interactions. Rifampicin decreases the level of Dolutegravir, so the dose of Dolutegravir would have to be doubled. Metformin levels are increased for patients on Dolutegravir, and so there's a maximum daily dose of 500 milligrams twice a day. And calcium supplements can decrease Dolutegravir concentrations if they're taken on a full stomach. So mothers just have to be counseled about who are pregnant about eating before they take their supplements. So there is a concern about neural tube defects, which the guidelines cover, particularly for women before 6 completed weeks of pregnancy while the neural tube is forming. However, in reading the data, it seems that there's the same results from the study that was conducted in Botswana haven't necessarily been reproduced in other settings. And one of the reasons, while I was reading, was that in certain places, food is fortified with folate. So I'm not sure whether there may have been a confounding variable in that study, but the guidelines do still advise caution, and which we'll come to later in deciding on the regimen. And then the guidelines say for women intending to have children prior to conception and up to 6 completed weeks of pregnancy, the old efavirenz containing regimen is recommended. And after 6 completed weeks or 7 weeks of pregnancy, it's perfectly acceptable to use the dolutegravir containing regimen. But the guidelines do stress that this is in consultation with the mother, explaining that the benefits of dolutegravir in the early stages are that it may be more efficacious. The side effect profile may be less than the efavirenz containing regimen, but there is this concern about neural tube defects. So the final decision about which regimen does lie with the mother, but as clinicians, we can recommend the dolutegravir containing regimen after 6 completed weeks of pregnancy. Next slide, please. Okay, so the guidelines also include a viral load non-suppression algorithm. I just want to briefly touch on the different factors that can result in viral load not being suppressed. A suppressed viral load is defined as less than 50 copies per mole, according to the guidelines. So the 5 main things are adherence, bugs, correct dose, drug interactions, and resistance. So the next slide has an image of, so this is the viral load non-suppression algorithm. It's very important to gain an understanding from the patient as to if there is poor adherence. There are many factors, mental health factors, the side effects of the antiretrovirals, and also poor social support. Sometimes patients struggle to have adequate food security to take their treatment. So it's extremely important that for us to try and understand the factors affecting adherence and to try and address as we can those factors. It's also important to look for co-infections, to do an STI screen, and to test for TB, and if the patient has symptoms suggestive of TB. It's also important to ensure that the correct dose of the treatment is being given, and important to remember that rifampicin decreases the dose of dolutegravir. So in that case, the dose would have to be doubled, which comes into drug interactions. In the next slide, sorry, the bottom is cut off, but the last thing is resistance. It's important to go through all these other factors first and ensure that the patient is adherent and all the other factors have been controlled, and then only we will consider whether or not the patient is resistant to the particular regimen that they're on, and then consider changing the antiretroviral regimen. You're ready.
Good afternoon. I'm Sandile. I'll be taking over from Chris. So I'll be talking about the antenatal PMTCT and then antenatal PERIPARTUM PMTCT. So as you know, we have ANC. This is where we try to give the best possible outcome for the pregnancy for moms and babies. So our aims during ANC would be to identify all women who are HIV positive, and then also would be to provide treatment as soon as they are diagnosed, so that we make sure that they are stay virally suppressed. And also we'll try to make sure that all the HIV positive pregnant and then breastfeeding women they stay virally suppressed. Next slide, please. So the antenatal PMTCT has and also PERIPARTUM. They have 3 categories where we'll be looking at the testing and counseling. We'll be looking at treatment, and then we'll be looking at viral load monitoring and management. Next slide, please. So with the antenatal PMTCT, so we'll be having patients who will be coming to book to us for the first time, or will diagnose or will find that they're pregnant at the clinic. So for these patients, we have to counsel them and then test them at the same time. And then we also have to offer couple and partner testing. This will be to help us to promote prevention and access to HIV care and treatment. So if a woman or a partner they test negative, we have to give information about HIV so that they know about the disease and then they stay protected. So sometimes we getting patients who still refuse to be tested. So for those patients, we still have to we have to do a post-refusal counseling, and then every time they come for follow-ups, we have to offer to retest them again. And then if a woman tests HIV positive at any stage, and then we find out that the woman has got children at home, we need to try and then test the other children at home. Next slide, please. So I'll touch on the treatment during antenatal PMTCT. So with the treatment, so the preferred regimen is the TLD, but then because TLD contains the Dolutegravir, we have to take in consideration the gestational age, of which now it will change if they come within the first 6 weeks. So that one will contain a nevarapine, but if they come after 6 weeks, then they can start a TLD. But then if they are non-HIV reactive patients, so they can continue their regimen with their treatment. But for the newly diagnosed patient not on HIV, so those patients are eligible for ARDS regardless of their gestational age, CD4 count, and the clinical stage. But before we started the treatment, we have to exclude contraindications, which we'll be looking at the TB symptoms, renal dysfunction, psychiatric history, and then we have to do bloods. So the bloods will be creatinine, looking at the renal dysfunction, because this regimen contains a tenofovir. Also, we'll be looking at doing a CD4 count, because some of them they'll require a prophylaxis. So with the CD4 count, we'll look at the, say it's maybe less than 100. So if CD4 count is less than 100, then we'll worry about the cryptococcal meningitis. And then we'll have to do a cryptococcus antigen detection test, which is, if it's negative, and then maybe the viral load is less than 350, those patients, they can be started on a TB prophylaxis for 12 months. And then if it's positive, the cryptococcus, the latex antigen test, so we have to send them urgently to hospital so that we can do an LP, and then so that they can be managed accordingly. So so the non-HIV reactive patients who are not on ARDS, but then they've been previously exposed, and then we have last viral load which are suppressed. So for those patients, we can start immediately on a TLD. But then if they're not on treatment, known to be reactive, but we don't have a recent or the last viral load, or if it was not suppressed, so we can start with the Dolutegravir regimen. So those ones will need the AZT, lamivudine, and also those ones. I'm sorry, those ones we can put on a TDF treatment regimen. So they will require AZT, 3CC, and Dolutegravir. And then all the women who are HIV positive, they should be referred to community healthcare workers so that they can get the support and then adherence counseling, and then they can get a pre and post delivery care. Next slide, please. So looking at the viral load, we have the 3 categories. So we have a newly diagnosed patient, which will be started on ARDS for the first time. For those patients, we have to do a viral load at 3 months on ARDS, and then we'll do the next one. Or if the viral load is less than 50, so we'll repeat it at delivery. So if we have another one, which is a non-HIV reactive woman already on ARDS, so we will do the first viral load during the booking visits, and then the next one, if it's less than 50, the next one will be during delivery. If it's a non-patient who is not currently on ARDS, but they've been ARDS exposed, maybe they went through a previous PMTCT, so we'll do the viral load at 3 months on ARDS, and then if it's less than 50, and also will be at the delivery. Next slide, please. So looking at the PERIPARTUM PMCTC, we'll have patients who come to us in labor, or they come to us in labor ward. Others, they come to us with BBAs born before arrivals. So those women we also have to test them, and then we have to offer couple counseling and partner testing. And then those those who refuse to be tested, they can still be done in post-refusal counseling, and then can be retested again when they come for a follow-up visit. If a woman tests positive in stage, it's the same. If they have kids, if they're positive, we have to test the kids. And then if the woman has an indeterminate or discrepant in HIV test results, we have to treat the baby of that woman as a high risk until we get the proper or the confirmation of the HIV status. Next slide, please. Touching on the treatment during peripartum. So the pregnant women already on ART, they should continue with their treatment. And then those who are newly diagnosed or known to be on treatment, they should be started on TLD. They should get a state dose of TLD and then a single dose of nevirapine. And then, but the lifelong treatment is required for them after we get the proper workout first. And then before we discharge these patients, we have to talk about the contraception. We give them different methods, and then they'll choose. And then we give them an HIV counseling education before discharge, and then adherence counseling. Next slide, please. Touching on the load monitoring. So for these patients, we'll check if they have a load in the last months, and then we will classify them into groups. So for those ones,
just check your sound once more.
Okay. Can you hear me?
It's just this dragging. Maybe it's the quality of the machine or something, but you had it right before. It seems to have gone wrong. Otherwise, you can carry on.
Prof, can you hear me now?
Carry on, it's fine. I'm sure you're close to the end.
Oh, all right. So touching on the viral load and monitoring. So we'll check the results in this case of the mom viral load results in the last 12 weeks, and then we'll further classify them into 3 groups from the viral load results. If they are less than 1,000, so those ones would be a low risk. But if they're more than 1,000, those ones would be a low risk. And then if we don't have a viral load in the last 12 months, those ones will be further also classified as a high risk. And then all women must have a viral load test done at the time of delivery. Although this won't be available mostly, although this will not be available the time we discharge them, but then we'll just put the stickers on the discharge summary so that the clinic can follow up with the results. I thank you.
Just to briefly cover maternal postpartum care, as Sandile mentioned, we'll follow up that viral load 6 days postpartum. Usually takes some time to get a result, and the antiretrovirals, importantly, will be continued throughout the postpartum period and the rest of the patient's life. The viral load that we follow up 6 days post delivery will help us to risk stratify the child. For that, we use 1,000 copies per ml. If it's less than 1,000 copies per ml, the child's considered low risk. And then we also want to see whether or not the mother is virologically suppressed. If not, then we use that viral load non-suppression algorithm that we mentioned earlier. And again, the guidelines say if the results are not available on the 6-day visit, then we check 1 day later, which will be 13 days postpartum. Certain areas may not be able to get a result in time. Then at the 6-week visit for the mother, we check and counsel our antiretroviral compliance, and we repeat the viral load if the delivery one was more than 1,000. And then at the subsequent visits at 10 weeks, we also check the viral load and adjust the treatment accordingly. And at 10 weeks, we also want to test HIV negative mothers. So 6 months is also a viral load check and test for HIV negative mothers. And then HIV negative mothers who are currently breastfeeding should be tested for HIV every 3 months, just to try and reduce the possibility of an infant being exposed while breastfeeding.
Okay, so I'll be doing the last bit of the presentation. So this slide basically addresses how do we help the HIV exposed infant at delivery and then going forward. So all HIV exposed infants are to receive a birth PCR, which is very important and should be checked, as Chris said, at about 3 to 6 days post-delivery. And all HIV exposed infants should receive a minimum of 6 weeks of post-exposure prophylaxis. And also it's highly crucial to identify who is high risk and who requires additional prophylaxis, of which a mother with a viral load of more than 1,000 at delivery, or most recent viral load taken during the last weeks of antenatal care. If the mother or the mother with no viral load in the last 3 months, so these are considered high risk, and these infants should be provided with high risk prophylaxis until the results of the delivery viral load can be checked at 3 to 6 days postnatal visit. Sorry. When delivery viral load result is known, the infant can then be reclassified as high risk or low risk, which then changes the prophylaxis can then be adjusted appropriately. So high risk infants who are breastfed should receive additional AZT for the first 6 weeks and should receive an Nevirapine for a minimum of 12 weeks. And NVP should only be stopped when the breastfeeding mother has a viral load, as mentioned, of less than 1,000 or 4 weeks after she has stopped breastfeeding the infant. All high-risk infants who are exclusively breastfed should receive 6 weeks of Nevirapine and then 6 weeks of AZT. And infants with unknown exposure, the mother should be tested at 6 months if possible. And if negative, there's no need to test the infant. But if the mother is not available or they don't agree to get tested, can test the infant. So this part I think Chris mentioned, so we do universal testing, which is a different, which is the adjustment that was made in 2019. So this universal testing for infants at 18 months of age who are HIV exposed. So in terms of the prophylaxis, as I said, it's important to classify them as high risk or low risk, depending on the viral load. And then all those that are exposed, they receive the cotrimoxazole preventive therapy, even if the PCR becomes known as negative. Then at 6 weeks, so the low risk infants can stop NVP, Nevirapine if the mom is less than 1,000. If they're high risk, you stop AZT, then you continue with Nevirapine for at least 12 weeks or 4 weeks after they've stopped breastfeeding. Then at 10 weeks, so the question was, when do you stop NVP, which I've just mentioned above. So if the mom is virally suppressed after 12 weeks, and then if they're not virally suppressed, then you continue with Nevirapine or 4 weeks after cessation of breastfeeding. I've already mentioned. Can you please go to the next slide? Okay, thank you, Prof. So how do we test? So any infant that's less than 18 months, we do a screening test with the PCR and then confirm with another PCR. And if they're between 18 months and 2 years, you can do a rapid, but you have to confirm with the PCR. And then if they're more than 2 years, you can confirm with the you can screen with the rapid and then confirm with a rapid. So last slide, in conclusion, Prevention of mother-to-child transmission is an important intervention strategy for HIV and requires collaboration of the community, the patient, and the health workers also. Yeah, that's the end of the presentation. This is the last well, references that we use for the presentation. So if there is any questions, we can go for it.
Good, thank you. Any questions, comments? Anybody like to add anything? Dr. Kabir, Dr. Maggie, Dr. Petkova, Dr. Aki, anything to add? All done. Presentation is very good. I don't think there are any comments to add. I think it's just a lot of detail that one has to.
I think it's okay from my side. I think that's fine. Yeah. The only comment I can add is that colleagues, you must try to be part of the activities in the HIV clinics and management of these patients. Then the it will be part of you when you talk of managing PMTCT. If you don't practice, it will go out of the window. Thanks.
Okay, good. So are interns actually getting into antenatal care MOUs at the clinic, CHCs? Is this happening?